Good afternoon, everyone. I'm Dr. Ying-Shuo Hsu from Taipei Xinhong Hospital. Today, I'm going to present this review paper, Neurocognitive Impairment in Obstructive Sleep Apnea. This paper is from the journal Chest. My advisor is Professor Ying-Shuo. The aim of this review is going to ask these three questions. First, is neurocognition and obstructive sleep apnea related? Second, will obstructive sleep apnea cause neurocognitive damage? Third, is neurocognitive damage caused by obstructive sleep apnea treatable or reversible? And why OSA related to the brain? We know that obstructive sleep apnea was caused by upper airway narrowing or obstruction when patients are asleep, and this narrowing and obstruction will cause desaturation in patients. We also know that this will affect the patient's sleep quality, so neurocognitive deficits may occur in obstructive sleep apnea patients with a high frequency. Those deficits include cognitive domain, that's learning, memory, attention, and vigilance. They also include emotional domain. They will cause emotional instability and make patients prone to irritability. Even with mild form of obstructive sleep apnea will cause these deficits. So this paper is going to review our knowledge about the effect of OSA on the brain. Epidemiology. The prevalence of cognitive dysfunction in adult patients with OSA is unknown. However, there is a prospective observational study which includes 49 consecutive patients with OSA, found that 1/4 had some neurocognitive dysfunction. And children with primary snoring may have more hyperactivity, inattentive behavior, and poor school performance in mathematics, science, and spelling when they have snoring compared to the healthy children. Even mild form of sleep disorder breathing, which is a mild form of obstructive sleep apnea, may affect neurocognitive function in children. Let's talk about pattern of cognitive impairment in OSA. OSA has a profound impact on psychomotor functioning, which include precise motor response, attention, and cognitive problem-solving abilities, and they will have impact on cognitive domain, which is attention, memory, and executive functioning. However, the global intelligence are relatively spare, so the OSA won't have evidence to affect global intelligence. OSA has been associated with mild cognitive impairment, called MCI. MCI is subtle but measurable cognitive impairment than with normal aging process. But the functional activities for MCI patients are preserved. Let's talk about risk factors for cognitive impairments in OSA. We can see those risk factors in this table. However, the association with these risk factors are hard to clarify because those risk factors may overlap with each other. And pre-existing cognitive impairment due to other causes may also exacerbate by OSA. So we need to know some knowledge of OSA-associated comorbidities. Let's talk about genetics. Familial aggregation of OSA has been found that European ancestry had higher risk of developing OSA. On the other hand, West African ancestry may have protective role of developing the OSA. Talking about genetic factors. In adults, sleep disorder breathing and neurocognitive decline is easy to find that some patients have ApoE4 positivity. And in children, when they have ApoE4 allele, obstructive sleep apnea chances are higher. In OSA children with neurocognitive impairment, ApoE4 allele chances are even higher. For Down syndrome, who present with OSA also have intrinsic neurocognitive disease from the genetic reason. For OSA medical comorbidities, comorbidities can influence neurocognitive function. These comorbidities include tobacco, hypertension, diabetes mellitus, congestive heart failure, cerebrovascular accident, hypothyroidism, and alcoholism. However, these comorbidities also have higher chances to develop cognitive decline. So this cognitive decline cannot be easily to differentiate from the reason of comorbidities or OSA. So this medical comorbidity including this. Cigarette smoking can cause Alzheimer's disease, dementia, and cognitive decline. Obesity can cause cognitive decline in men. Metabolic syndrome, which include hyperlipidemia, hyperglycemia, and obesity, can cause cognitive decline. Hypertension can cause dementia. And these findings may be due to cerebral vascular accidents for these children, these patients. So, independent role of OSA to cause cognitive decline are unknown. Let's talk about demographic factors. Demographic factors including sex and age. This can impact cognitive decline in OSA patients. Aging itself can cause cognitive function decline, and prevalence of mild cognitive impairment is higher in men than in women. And the presence of OSA in an aging population constitutes a double insult, because when people are older, they have higher chances to develop OSA. They also have higher chances to have cognitive decline. Increased age reflects a greater duration of OSA prior to diagnosis, which can exacerbate cognitive decline. Other OSA medical comorbidities, including hypothyroidism and alcohol consumption. Hypothyroidism is a risk factor for OSA and it also can cause reversible dementia. If we treat hypothyroidism with thyroid hormone, but we can find that neurocognitive impairment may not reversible, and this may because concomitant obstructive sleep apnea. Alcohol consumption can cause memory loss, personal deterioration, and impaired judgment. Alcohol increases upper airway instability, as we know. Alcohol intake close to bedtime also can impact sleep architecture, which include increased slow wave sleep, rebound, increase in rapid eye movement and sleep fragmentation. Alcohol can also worsen underlying obstructive sleep apnea. Let's talk about stroke and OSA. We know that snorers have increased the relative risk of stroke. We also know that association between mild to moderate OSA and stroke existed. Silent brain function can increase in the patients with OSA. What is silent brain function? They have platelet activation and systemic inflammation, which is found by higher C-reactive protein. So these are the risk factors of develop silent brain infarction. And after the use of nasal CPAP, these biomarkers can decrease. So stroke, transient ischemic attacks, and silent brain infarction are risk factors of dementia and cognitive decline because they all affect the brain. Sign of cognitive impairment in patients with OSA is secondary to stroke. Let's talk about psychoactive medications. Benzodiazepines, narcotic, barbiturate, and atypical antipsychotics can worsen underlying OSA and can cause problems with attention and vigilance. So polypharmacy is common in the older people. The impact of OSA on cognition in the old people can increase because they use a lot of these drugs. So OSA has both direct and indirect effect to the cognitive decline. Because OSA has numerous comorbid conditions which can interact to cause cognitive impairment. And OSA can also have direct effect on the cognitive impairment by excessive daytime sleepiness to cause brain cognitive dysfunction. So there is a unique patterns of cognitive impairment in OSA. There are two broad areas of abnormalities being found in patients with OSA, which include cognitive function and psychomotor performance. Psychomotor performance means the coordination of sensory or ideational process and motor activity. We can know that cognitive function include intelligence, which is ability of abstract thought, reasoning, and comprehension. This cognitive function will not be affected by obstructive sleep apnea. However, executive functioning, motor functioning, and vigilance can be affected by OSA. Executive functioning include working memory, planning, problem solving, inductive reasoning, which means moving from a specific observation to a broad generalization, and deductive reasoning, which means moving from generalizations to specific outcomes. This psychomotor function can be impaired by OSA. And there is also vigilance, which means ability to maintain alertness for a prolonged period of time. When vigilance is affected by OSA, patients can increase the risk of motor vehicle accidents. Let's talk about brain imaging of OSA. There is various neuroimaging techniques used in OSA include structural MRI, functional MRI, and magnetic resonance spectroscopy. Some studies have shown the differences in OSA patients than in healthy adults in deep white matter, periventricular hyperintensities, and in gray matter. And other studies have suggested there is a decrease in gray matter in the hippocampus, anterior cingulate, cerebellum, the frontal, parietal, and temporal lobes in OSA patients. We can see this figure. It studied 42 OSA patients and compared them with a healthy adult. They found that these are the difference between these two groups, which include posterior lateral parietal cortex impairment, anterior superior frontal gyrus impairment, and ventral lateral frontal cortex and left temporal lobe impairment, and parahippocampal gyrus impairment, and lateral prefrontal cortex impairment in OSA patients. So, a lot of studies showed the common finding, which there are decreased hippocampal volume in OSA patients. Decreased hippocampal volume can cause anterograde and retrograde amnesia. In the animal model of OSA, in a junior pig, they found that there is recurrent apnea can produce high glutamate. And this high glutamate can promote excitotoxicity to the hippocampal neurons, which in turn cause apoptosis of hippocampal neurons. The other study showed that frontal and parietal cortexes are affected in OSA patients. This can cause decreased brain activation in cingulate, frontal, and parietal regions during sustained attention tasks. And to continue, that there is focal reductions in gray matter in OSA patients, which include anterior cingulate gyrus. This structure is responsible for pain perception, and this damage can cause upper airway sensation and motor control impairment, and this can in turn cause worsen OSA symptoms and reduce respiratory drive or muscle tone. And they also found that treatment of OSA can reverse gray matter loss on brain imaging. Before treatment, focal reductions in gray matter volume was seen in left hippocampus, left posterior parietal cortex, and right superior frontal gyrus. Then after treatment, there is significant improvement not only include cognitive domains, but also they can find that they can increase gray matter volume in hippocampal and the frontal areas. A more recent study showed that when they compared the 17 OSA patients before and after treatment, they can find that white matter integrity measured by diffusion tensor imaging (DTI) improved after 12 months of continuous positive air pressure CPAP. They found that almost complete reverse of white matter abnormality in the affected regions. These are the example. We can see that the original impairment is this whole area. Then after 3 months, the impairment area becomes smaller in only this yellow region. And after 12 months, the impaired region of white matter remain only in this small area. Furthermore, we can compare the CPAP treatment into two groups, which are sleepy group and non-sleepy group. Sleepy or non-sleepy can reflect the treatment response. When we compare these two groups in 29 male patients after using CPAP for 1 month, we can find that mean diffusivity of these two groups difference in the yellow area. This means white matter alternations in OSA may reflect the OSA responsiveness of CPAP effectiveness, which means the non-sleepy group may have better treatment response in these areas. Let's talk about pediatric brain imaging of OSA. We can use proton magnetic resonance spectroscopy to identify the neuronal injury. How to do that? We know that nitrogen acetyl aspartate means myelin synthesis is a marker of myelin synthesis, and choline is a precursor of acetylcholine. If choline amount is abnormal, that means degradation of the neuronal cell membrane. So if we find the decrease in nitrogen acetyl aspartate and found the higher level of choline, and this ratio can be used as a marker of neural injury. We can see this example in the figure. This figure shows how to identify the hippocampus regions of the children's brain. Then we can draw a diagram which can show the nitrogen acetyl aspartate and choline ratio. So what can we find? Children with severe obstructive sleep apnea will have not only significant deficits in executive functioning, they also have decreased mean neuronal metabolite ratio, which is nitrogen acetyl aspartate to choline, in the left hippocampus and right frontal cortex. This study implied that untreated obstructive sleep apnea could lead to a permanent decrease in child's overall cognitive potential. So, pathophysiology of OSA to cause cognitive function can be explained as 3 parts. First is endothelial dysfunction and hypoxia. Hypoxia and the reperfusion injury caused by increased lipid peroxidation. Increased lipid peroxidation can induce free radicals, and free radicals can steal electrons from the lipids in cell membranes, then cause the cell damage. And oxidative stress can make soluble adhesion molecules level high, and other reactive oxygen species potentially higher. So these molecules and reactive oxygen species are harmful to the brain and the heart. So the hypoxia and inflammation can cause endothelial function, then in turn cause cognitive function. then endothelial dysfunction can cause mechanical dysregulation, and this can alter cerebral and myocardial perfusion. If cerebral and myocardial perfusion are impaired, hypercoagulability can predispose to atherosclerosis. We know that atherosclerosis are the main reason of blood vessel obstruction. So, if there is endothelial dysfunction, we can find imbalances between vasoconstrictor, endothelin-1 thromboxane, and vasodilator, nitric oxide, and prostacyclin. Obstructive sleep apnea can decrease the production of nitric oxide, which in turn reduce the cerebral blood flow. Then cerebral oxygenation will be impaired. Then it will cause brain infarction. Excessive daytime sleepiness is another unique feature to OSA patients. Excessive daytime sleepiness can slow the information processing, which in turn cause impairment of attention, vigilance, and memory. And these findings is like sleep-deprived patients. And cognitive dysfunction only partially reversible with CPAP treatment after complete resolution of excessive daytime sleepiness. So, additional mechanisms for cognitive decline in OSA may exist. Just like this study, sleepy group and non-sleepy group may have different presentation of white matter repairment or injury. In conclusion, OSA with cognitive impairment is complicated by numerous comorbidities. The neurocognitive decline in patients with OSA have unique clinical syndrome, which include attention and working memory decrease, and vigilance decrease, and executive functioning decrease. However, language and global cognitive functioning for OSA patients are relatively spared, not impaired. In the future, we can collect more sample size, we can standardize methodology and to measure cognitive impairment in OSA patients. And we need to specify comorbidities and OSA to each other. And we need long-term follow-up. And we should separate cognitive impairment separately. New tools specific to OSA to measure the neurocognitive dysfunction should be developed in the future. More future work include more specific functional neuroimaging to delineate the affected brain regions in OSA patients, and in turn to imply us the long-term implications. And we need to develop potential strategy to reverse the cognitive decline in OSA patients. An identification of neuromediators may help to establish the new therapeutic targets for intervention. The impact or treatment on cognitive impairment should be studied more in the future. We know that CPAP therapy can improve daytime sleepiness, and it may slow cognitive decline in patients with comorbid Alzheimer's disease and obstructive sleep apnea. So, medical, pharmacological, environmental, and genetic covariates, which are very important to affect the outcome to OSA patients and cognitive dysfunction, should be studied more in the future. We also need to develop other treatment to OSA to see if they can improve cognitive function in the future, because we know that CPAP compliance are not very promising. There is another review paper recently which found that 70 papers reported neurocognitive performance improvement in OSA patients after CPAP therapy. And 80% of studies found improved executive functions such as verbal fluency or working memory with partial neural recovery at long-term follow-up, which means that if we can restore the patient's airway when they are asleep, it is likely to improve or reverse patients' cognitive function. However, there is only one article compared the effect of mandibular advancement device, and they compare it with CPAP treatment. Those two therapies can improve patients' cognitive function after the treatment. So we can restore or repair the patient's cognitive functions also by intraoral negative airway pressure, mandibular advancement device, or surgery, which have no problem with the compliance as CPAP. This is my talk. Thank you for your listening.